Thank you so much for the wonderful introduction. So I don't think I need to introduce myself any further. I'll just go straight into the discussion. I'm calling it more of a discussion because I believe it should be a two-way interaction. It's not one way. I expect feedback from you as I'm also giving you feedback of what I have done. So I've chosen to present this to you in the sense that TB is the disease of poverty. So usually where there is no poverty, very few people actually come to interact with TB. And because of that, and it's my opinion to say that that's why a lot of actually people don't care about TB, because the people who've got the resources to be able to get rid of TB, it does not affect them. So they don't see a need to actually act or work on TB. So this presentation is about giving us an insight on how we can address all the causes of morbidity and mortality as a result of TB. I can tell you TB mimics anything and it can go anywhere. So most of the times actually you may end up treating something else whilst it's just TB. So this comes to my title, which says Health System Strengthening for Tuberculosis. I'm going to focus more on multi-drug resistant TB. And the reason for that is that's what I'm currently working on and trying to make a difference in that area. So I want us to see what's the role of an anesthesiologist and critical care specialist in tuberculosis, because I can tell you most of the anesthetists that I've seen, they don't see any need of anesthesia as well as critical care in tuberculosis. They think it's just for infectious diseases. So this is not my saying, it's borrowed. It actually comes from someone from here in California who said something, "Oh, war is a failure of man as a thinking mammal." We know that war never breeds any good. It kills humans, it causes devastations, but we still go for it. So it's the same thing with TB. I'm telling you, we've got, as a world together, we've got the resources which are needed to fight tuberculosis. We've got the brains. I can say we basically have everything, but we still just decide to either neglect it or not pay attention to it. And it keeps on going from generation to generation, even after discovering more and more things that we can use for fighting tuberculosis, we just don't care. So that's why I've also come to coin it as to say is TB is also a symptom of man's failure as a thinking mammal. So what I want to bring to light to you are the following, okay? I want to use TB as an example of how we can strengthen systems. And I also want to tell you the burden of tuberculosis. A lot of people actually have forgotten about it because it's a disease of the poor. And then I want to bring to light now how, as anesthetists, anesthesiologists, and critical care specialists, we can actually buy into tuberculosis to help fighting this pandemic, to say. And then I would also like us to understand something which personally I think has been a cause of confusion about horizontal health systems and vertical health systems, and how we can buy into these two kinds of systems to be able to help in the fight against tuberculosis, but most of all, to advocate for people to join into the fight against tuberculosis. So, as Anna said, I'm an anesthesiologist and critical care specialist. I've been doing more of Are you able to see my point? Oh, it's there. Okay. Yeah. Yeah. So I've been doing more of humanitarian medicine over the past 6 years or so. And I can say it's something which came to become an interest for me when I actually went to a country called Yemen. Okay. I had an opportunity, I think, at the peak of the COVID pandemic. I went to Yemen to actually work in a COVID hospital. But one of the things that I actually found when I was there is this. Okay, I'm going to give you this X-ray. Just from the audience, let's just go back and say we are in 2020. It was during COVID. What diagnosis do you think you would have given this patient? Anyone? Okay, yeah, that's true actually. That was the most common diagnosis actually, which people would have given this patient. But I can assure you 100% that this patient, it's not COVID. This is actually TB. And it's drug-resistant TB. So for this patient, so imagine what was happening at that particular time is that this patient would be rejected to say this patient has COVID. Remember, initially there was a lot of hospitals rejecting COVID patients, but at the same time, there were no facilities to actually to be able to treat a TB patient. So that's how I actually came to take interest and says, okay, this is quite very, very, very interesting. We did a lot of tests to actually confirm whether this is, we even did the CT scan for this patient, but actually just came out to be, it's actually just TB. So this patient was even given COVID treatments and all that, but the patient never actually responded just because it was TB and the patient was rejected. Fortunately enough, because it's MSF, so we're able to accept the patient and be able to treat the patient, and the patient actually eventually recovered and went home. So this comes to my question is, should anesthetists take interest in tuberculosis? What do you think? Even when we just go back to look at this, don't you think that this actually fits the picture of ARDS? Isn't ARDS managed in intensive care units most of the times? That's under critical care. But it's just that this ARDS in this particular case was actually caused by TB. You may likely even going to treat this patient for viral, other bacterial treatment or broad spectrum antibiotics. They won't work, but still the patient will have ARDS and septic symptoms as well. So on this, I can say of these three options, I would go for yes. Anyone else with a different opinion? Okay. So I can say we all agree. Since there's silence, it means we all agree. So let's go on. So why, for me, on my side, I don't know, I'll leave that to you to decide on your own. But for me, actually, why I think an anesthetist should also take interest in tuberculosis is sometimes you can just have a passion for infectious diseases. It's not all the time that an anesthetist should actually treat non-infectious brain tumors and all that. Sometimes even TB presents with tuberculomas, which you may actually think it's actually a tumor. So just having the passion for that for me on my side. And then I also came to find it as in TB is a very challenging and complex disease. Very simple, but very complex and challenging. And then it also brings about a lot of specialties in the management of one disease. And lastly is I just think is I'm able to make more impact if I deal with TB because it's It's a pandemic. Almost every other country is actually affected by it. Let's go to the next. What can you see from this X-ray? Anyone who can say something about this X-ray? Sorry, I'm coming from a low resource setting. So a CT scan is not something that you just cough at will. You need to have a high justification for it. So X-rays are the basic tools that we use for diagnosis of TB. Anyone who can say something about this X-ray?
Looks like it runs bilaterally.
Okay. Yeah. So this patient actually has got bilateral upper lobe. This patient doesn't actually have lungs. There are no lungs here. There's no lung here. You can just cut it from here up. That's a bullet. There's no lung. Equally, this side as well. This patient basically just has 50% of the lung capacity. And this same 50% has got bronchiectasis in them. There are coarse nodules and fibrotic changes in the remaining 50% of it. Okay. This is another patient. This is one patient, but now this is a CT scan. So we went further to do, it's a different patient. Don't think it's that other patient. This one, we went further to do a CT scan, which I'll explain later why it is like that. If you can look at this patient. Okay. On the first image, we are going to see that the upper lobe this side is basically eaten up. But when you go to the second image, okay, here, not only the upper lobe has bullae, but have you seen what has happened to the trachea? This is of interest to you anesthetists. This is a trachea. This trachea you are seeing here, this is just at a different level where it is at. When you go further, after the carina, there is a bifurcation into the bronchi. Sorry. Just at the back. Okay, so you've seen here. One of them is smaller than the other. When you actually go further deeper, you've seen this bronchi is supposed to be like this. So do you still think TB is not of interest to an anesthetist? I know you love intubating. How are you going to intubate this patient? How are you going to intubate this patient? Because I'm telling you, this level is quite very high where it is actually. It's not that it's way deep down. It's actually almost just below the vocal cords. When you just move slightly below, that's where that stenosis is. Where are you going to put your double lumen tube? How are you going to? Those are the things that we get from TB. What of this patient? What can you see from this patient? Okay, for the sake of time, I'll just say this patient basically just has one lung and it's hyperinflated. The whole lot of the left lung is collapsed. And in addition to that collapse, there are bullous lesions, there are bronchiectatic airway changes, and there are multiple cavitating large nodules in there. I'm giving you that more additional information because we are also able to do a CT scan for this patient as well. Okay. So I'll give you a bit more history to this patient. This patient is actually only 36 years old. The patient is male, HIV positive. The CD4 count is quite good. The viral load, we call it low viremia. It's because it's not undetectable, it's state. And there's been on what you're seeing there's TDF3 TCDTG is just tenofovir, lamivudine, and dolutegravir. It's the most common regimen that we use for HIV treatment. He smokes. I didn't have much more details on that. He takes alcohol occasionally. He has no any previous surgical or other medical conditions, but he was a minor. This is his history. So In 2018 to 2019, he was treated twice for drug-sensitive TB. So what you're seeing there is RHEZ is just actually rifampicin. I think here in America, you call it as rifampicin or something like that. You've got a different name, but the most common one that we call it for is rifampicin. H is isoniazid, E is ethambutol, and Z is pyrazinamide. So he was treated twice in this period of time because the treatment is 6 months. So 6 months, there was still failure. He completed the treatment, the TB didn't go away. Again, in 2021 to 2022, he got treated with this regimen you are able to see here. This is just LFX is levofloxacin, BDQ, bedaquiline. So these are just drug-resistant TB treatment. So if you've seen, there are 1, 2, 3, 4. He's been treated about 5 times for TB, and this patient hasn't been getting well. If I can take you back, this is his X-ray. It never changed. From the beginning, it was like this. And even after the last treatment, which we started in October 2022, up to now, because it was put on a 24-month regimen, is still on this treatment. The X-ray is still like that. These are just other health status conditions. His BMI, I can say it's about 18 point something. A lot of things are actually normal. We never ever did a spirometry on this patient. So the big question is, what do you think should be done for this patient? What's the next thing for this patient? Basically, this patient has used up all the drugs for drug-resistant TB, all the drugs for drug-sensitive TB. The solution is very easy. So when we go back here, the TB drugs are unable, where is it? Okay. Where is the pointer? My pointer is not working. Okay, yeah. So this area, this is where the TB is. The TB medication cannot penetrate in there. It's formed scars. So the drug is unable to move from the bloodstream to go be able to treat it. So what do you think is the next thing to do? It's to actually remove this lung. You have to do a pneumonectomy. That's the treatment. So you see where now you as an anesthetist comes into. You may keep on rejecting this patient to say, no, treat, no, give this. I'm telling you, no matter how much medications you're going to give this patient, it won't be treated. This patient's sputums are positive, like 3+. So wherever he's working, he keeps on infecting other people, just because people are refusing to say this patient is not a surgical patient, but should be treated, because everyone thinks TB treatment is medication, not surgical. So this is how we come here. So the next course of action is to actually do surgery. But the next thing is that for this patient, do you think it's an emergency or it's an elective case? I'll give you these pointers. No matter what you will do for this patient, no matter what medications you're going to give this patient, the sputum is not going to ever be negative. You can wait a year, it's never going to be. The patient will just keep on infecting people. So you have to operate this patient. ASA, I know, made up some guidelines a long time ago about TB, how to approach TB cases, which I think, and these are some of the guidelines from that. If you can see here, they're saying the patient should be on treatment for 2 to 3 weeks. It won't work for this patient, even if you wait. The only thing maybe you can also say is, will the patient have a clinical, because the third point is clinical improvement and having 3 negative sputum. It will never work. This patient will actually keep on deteriorating. So the more you actually wait, the more the patient deteriorates. And then it should be the last case of the day. Fair enough. It's good. It makes sense. There's logical case to that. You can do that. Yeah. So for emergency, so for this case, to me, I would classify it as an emergency, actually as a public health emergency. I won't classify it as a clinical emergency. I know there is a thinking of, no, the patient is right now a bit stable and all that, but you don't know how much damage this patient is actually doing when they're moving in the community. They are actually transmitting a drug-resistant TB, which is primary resistant to other individuals out there. Okay. So the treatment consideration is you don't need to do further cultures, or what DST means is drug sensitivity for this patient. It won't help you at all. What you need is to eliminate the focus to operate. I just want to give you something which is, it's a new concept which has come up. I think it's always been there, but we never paid attention to it. It's what we are calling post-TB lung disease. So even after you can treat a patient with TB medications, they still end up with complications. And among these complications are bronchiectasis, COPD, aspergillus related, like, you know, when they form those cavities, aspergillus actually accumulates in there. And when aspergillus accumulates in there, even if you use the antibiotic of choice is an antifungal, I've forgotten the name, okay? It won't ever get into that cavity because there is a fibrous tissue which forms around it. So at the end of the day, you may need to chop off that part of the cavity. Others will actually develop copulmonary because a lot of them actually develop pulmonary hypertension on it. Okay. This is the same thing. I just summarized them to show you like extensive pulmonary distractions, which I've already shown you. So all those images that I've shown you there, almost all these are there: lung fibrosis, tracheo and bronchial stenosis, bronchiectasis, COPD, aspergillus. All those images I showed you there, these are there. And these patients, I can tell you, they are still with me on active treatment and management. It's not that they are old patients, they're still in the TB program. So this shows you just how TB is. So if you think there is no TB somewhere, it's there. It's just the incidence or prevalence which differs. I know in some countries, like where, you know, Lesotho, it's down here, where there's South Africa, the incidence and prevalence are high. But if you can see globally, almost all the countries, there is TB. So even here in the United States, you have TB, just that it's of a lower prevalence. This just summarizes a few things to say is, for TB, as an anesthetist or critical care specialist, you will encounter it, one, as either you'll be doing it for diagnostic purposes, because there are times when you actually need to get a biopsy. You know that TB can actually present and be like typical like a lymphoma. You may actually treat it, start even treating as a lymphoma, but there will be no response. So you may need to get the biopsy. So regardless of that, you need that. Bronchoscopies are the order of the day. And in children, you may need to anesthetize them. You won't be able to do a bronchoscopy in a child by cooperation. Laparotomies, laparoscopies, they will be either because of TB, abdomen itself, or as a result of other things which is causing that, but the patient also has TB. Thoracic surgeries, lobectomies, pericardectomies, these are the order of the day where it's actually prevalent for us. Okay. So I just now want to show you the challenge which is there. So this is a very good OR in a low resource setting. I'm telling you, this is a well-resourced ICU in a low resource setting. But when you look at this, there are just two ways in which you can actually, the ventilation systems for TB. It's either one, open system, where the windows are open, there's cross ventilation. So there's supposed to be windows everywhere so that there's cross ventilation. That's one. The second one is negative pressure. But when you look at this, do you think there is open system here for ventilation? None. And I can assure you there is no negative pressure ventilation as well. But you as an anesthetist, they expect you, even if it's at the end of the day, to still come and do and anesthetize the patient in this same OR. So those are the challenges that you may face as an anesthetist. Are you going to refuse? That to say, no, it's very highly hazardous? I'm not sure. But what you can do is risk benefit. You can wear an N95 mask, and other measures to say is you reduce the number of people in the operating room. You give the patient also, when they're coming into the OR, they should also have an N95 mask. So basically, you won't have the recommendations that CDC has. So CDC, when you go to the CDC website, you find a whole lot of recommendations of IPC, which is infection prevention control, in the OR for TB patients. So this one I just wanted to tell you. So this is a patient who had actually a hemoglobin of 3 grams per deciliter because of huge fibroids, but also had active tuberculosis at the same time. Are you going to make this patient wait longer to say it's no, after 3 weeks or so, after the patient becomes sputum negative, that's when we're going to operate? I don't think so. So the other thing that you should also notice is that since TB is a multi-organ disease, like it affects all organs, when these patients actually present to you, one, they'll be severely malnourished. A lot of them have got a BMI of less than 16. The hemoglobin is also usually less than 6. And sometimes you may not have platelets available. They tend to come with pancytopenias. And the blood banks usually are unable to produce platelets, because platelets, you only get them from fresh blood, and they've got a very short lifespan. So you won't be able to have, like we had a patient just 2 weeks ago came in with a platelet of 19, but no any other symptoms, wasn't even bleeding or anything, but the platelet was 19. So they also have deranged blood pictures. If it is about actually the liver enzymes, they are always in the roof. They are very high, especially those who it's affecting their liver as well. Depending on whether you're going to do regional anesthesia for them or it's general anesthesia, it will depend on what you're doing. But something I can assure you is that there is very minimal interaction between the drugs that we use in anesthesia and the drugs for tuberculosis, especially in multi-drug resistant TB. So it's not something of much worry regarding to that. But it's just the patients who present very sick and very unstable. And most of the times they need emergency surgery to them. So as an anesthetist, you are really, really needed in these patients. So if you have to even optimize, as you like to say, you have to be involved. If you leave it to a physician to optimize, I'm telling you, it will never happen. Okay. So I'll take an opportunity from this to ask you is that then how do we address all the causes of morbidity? Imagine all this time we have been talking about, no, TB, we need to treat them with medications, but we are actually forgetting about the other morbidity, causes of morbidity and mortality, which are surgical. So how do we do that? So from this, that's why we pose this question to say is, we need to strengthen the health system. And to strengthen the health system, we need number C. We will need workforce, health information systems, essential medicine. Usually this is where the TB has focused so much, essential medicine, providing medicines, and a bit of knowledge finance for medicines. But the health workforce, we are only looking at infectious diseases. But all those patients I've shown you there, they won't be treated by infectious diseases. They will need anesthetists, they will need surgeons. There is governance and service delivery. There are many things that we can argue around this topic, but however, what's the bottom line is that if we don't actually capacitate all of them, if we don't have adequate and appropriate health workers, if we don't have the information needed, like I have given you, what I'm giving you is actually information about TB. If people don't have that information, medicine, machines and technology for diagnosis, we need it. Financing, it's already there. I'll talk about it later. And governance. To me, I feel like governance is the most important thing. Other people may disagree. It's a personal opinion because I believe when the governance and leadership is good, it can be able to influence all the other pillars. When there's a political will, remember what I was telling you about the war, is that if there's just a political will to do something, something can be stopped. Equally for TB, it's the same. If there's a political will to actually address it, they can realign the budget lines to be able to support TB treatment. Okay. So I just want to give you just a small perspective since I'm coming from Lesotho. So when you look at it here in this, what the line that I want you to focus on is the most is this line here. The TB incidence in Lesotho, it's 661 per 100,000. But globally, it's 133. So meaning it's almost 4 times the global average. But this is a low resource setting, which may not be able to afford to be able to fight TB on its own. And it's not that people don't visit, they don't go to Lesotho to visit, and it's not that people from Lesotho don't go out to visit. Those people are still carrying TB. So just a small comparison. So since we agree there is TB in America, but I just want to give you just a difference so that you appreciate. So in America, you're going to notice that the predisposing factors for people to having TB is actually alcohol disorders and smoking. Whilst us, it's lack of food. That's undernourishment. It's just lack of food. It's poverty and HIV. There is even alcohol disorders are also there, but look, they are almost less than at 2K. But when you go that side, it's the highest for the developed settings. So to also just highlight you a bit is that you just see drug-resistant TB, drug-resistant TB. What is it? So drug-resistant TB is just TB which has developed resistance to what we use for treating. But what we are worried about the most is what's known as multi-drug resistant TB, which is resistance to isoniazid and rifampicin. These are the core drugs in the treatment of TB. But they are also what we call extensively resistant TB, where now it goes to fluoroquinolones, bedaquiline, and linezolid. This TB, I'm telling you, it's very difficult to manage and treat. And I've noticed that a lot of patients actually still even end up dying despite that. And one of the funny things is this. So there are these companies called Safeide and Danaher. Danaher, they manufacture, you know GeneXpert, right? What's GeneXpert? GeneXpert is just a molecular testing module for TB. It's manufactured by these guys. So these guys, MSF did a study to see how much it costs for them to actually produce those cartridges for diagnosis. It costs about $3 to $4. But they were selling it at $16. So basically they were making a profit of, I don't know how many times that is. So even if, for example, they had to sell it at $10, they would still make 100% profit. But this is a disease of the poor. It's the one that you're actually going on to make a profit of, I don't know, 5 times, 3 times 5 is 15, something like that. So they would still make a profit, even if they actually sell it at $8, $9 per cartridge. So these are the things which are actually pushing us back in the fight against TB. And that's what I'm saying is that TB a man is failing as a thinking mammal. If you look at it in this way, a lot of people may be thinking, no, TB actually, financing is actually international. It's actually not. When you look at this, blue is domestic funding, and then the red is actually international funding. So most of actually the treatment is that their individual countries are trying the best that they can from the limited resources that they have to try and fight it. The international community is only supplementing a little on top of it there. And what's funny is that you may find this to be very little money. The cost of treatment for TB is about $5,000 in our settings. But this is a lot of money in our settings because over 60–70% of the people live on less than $1 per day. So $5,000 become just a huge, huge amount of money to them. So this one prohibits them from seeking treatment and just pushes them back into more poverty. So I come back to the USA. I'm unable to explain. You see, us, that side is $5,000 to treat TB. But in the USA, it's 567,708. Why? I don't know. Probably it's the system. But this is very expensive. And have you seen, this is just direct treatment costs. When you actually now start adding other things like societal and whatever, it's even going to 800. And even here in the USA, the people who are affected by TB are those alcohol abusers, the poor, the homeless. Where are they going to get such amounts of money? This just shows to say, you've seen, the first one is showing all LMICs, which are low middle-income countries, and then there's the African region, and then the region of the Americas. The way people are being pushed into poverty, there's no much difference between America and even Africa, despite that difference in the costs. The point is, TB is pushing people into poverty. Economic impact, I've already told you about it. It's actually pushing people into poverty, but there's also a social impact as well. A lot of us actually, even as an anesthetist, we don't want to deal with TB, not because it does not concern us, but because of we stigmatize. We think we may get infected. So there is also a social stigma. Even for people with TB to have movements, there are even countries which puts up barriers to people with TB to move. Imagine when you have that bad X-ray that I was showing you, even if you treat someone, there are residual effects which remains. But if I go and get an X-ray, I'll be able to be denied entry in some countries to say that you may still have TB, even if I've actually been treated, but that's just fibrosis which has remained. So this brings me to what I was telling you about. There is a horizontal health systems and vertical health systems. So a vertical health system is whereby you focus your money on one program. For example, if it is HIV, you say, I'm going to fund HIV for its treatment, and I'll set up even, for example, a hospital on its own, which will be treating HIV patients. And then horizontal health systems whereby you have everything in one place. Like when a patient goes to a setting, they'll be able to access surgery, pediatrics, or everything in one place. But a lot of us people, this is where we are actually, I think, getting it wrong. We are unable to mix the two. There are certain diseases which needs a vertical health systems, and then there are a lot of diseases which just needs a horizontal system. But like, I'll give you an example for TB. We have a TB hospital, but we don't have cardiothoracic surgeons. So meaning we need to go back to a system which is horizontal, which has those personnel in it. So you don't need to say in our system, it will just be vertical, and in our system will just be horizontal. You actually, I think, need all of them but you just need to find a way of integrating the two. You may need the vertical system to actually get money and funding for TB. And then from that system, you can be able now to integrate it into the horizontal system and be able to pay and acquire skills which are in the vertical system to be able to form something which is, it's a risk balance. There will never be a system which will be perfect. I can tell you there is no system on earth which is perfect. But the goodness of how a system works is about how well it responds to the needs of its patients. How well it's not being rigid. I think that's a wrong statement. I can say, if you remove the rigidness in a system, is what makes it better to be able to respond. If you are rigid to say we just want a horizontal system, you may not be able to get funding for some things. If you just say again, no, I just want a vertical system, your patients may not have access to things. And for me, these are some of the barriers and challenges that I have seen on the aspect of us as anesthetists and critical care specialists to actually integration and going into this. So the first one that I'll say is we have got a misguided approach at undergraduate for anesthesia. I think anesthesia hasn't been a core subject for a long time in a lot of training programs across the globe. I think in some it's better than others. The other one is task shifting. There is already a fight between physician anesthetists and nurses. You can't seem to find a way of coexisting and working together other than restricting. No, you can only do this, you can only do this. At the end of the day, you're losing focus. What you have is a patient. You are fighting. What you need is to save the patient. If we can be able to come together and find amicable ways, we'll actually start finding some of these solutions, okay? The other one is we are trying to make training more complex without actual evidence to say that when we make it more complex, it's actually going to improve care. I've tried to look for research which has actually tried to compare to say that when you make training more complex or more difficult, actually patients are saved more. I'm yet to find one. If I'm mistaken, please send it to me. Instead of simplifying training so that we can have more and we save more people, we are actually making it more complex so that we're actually having now fewer anesthetists with skills needed to actually save our population. And in doing so, we're making our training even longer, pushing people in more debt in trying to train. And at the end of the day, what will that person do? That person won't be able to save the poor. What they'll try to do is to find a job which has got more money so that they can pay off the debts that they have accumulated for their trainings. And then the other one is we are not buying into other programs. I'm yet to see anesthesia buy into HIV programs. HIV programs have got a lot of funding, but I don't see components of anesthesia in those programs. The other ones that I've also seen is with time, other people will say, for me, my career is clinical, my career is public health. The more we separate these, the more we won't be able to talk to each other, the more we'll be doing things dichotomously. The public health guys will be doing their own things on this side. I'll give you a very good example of what had happened in Zambia. At some point, there was a cholera outbreak, but the people who made actually the treatment guideline for cholera, like case management, were public health. And when we looked at actually that guideline, all that treatment which was in there was obsolete. They have the clinicians themselves that stopped using it. Why? Because the two are unable to come together. This, I've already mentioned it, thinking of the one size fits all. This is what should work. It shouldn't be that. Even in one system, you can have hybrids, which should be able to respond to the needs of the people. And we should never get stuck just in one approach. So, for me, these are my suggestions of how we can actually improve what we already have. One is instead of making training more complex and all that, let's just strengthen what we already have, okay? If it's an internship, we can include more anesthesia training so that in those where it's less privileged, those doctors who go there can be able to have some knowledge and be able to treat patients who may have TB or diseases of the poor. Or we can also just expand the undergraduate training program so that it contains a bit longer training in anesthesia. These are just food for thoughts. The other one that we can also do is we can use the ECC, which is Essential Emergency and Critical Care, okay? Where we actually extend, you know, initially we used to think of critical care as ICU, but let's take it to the general public. Let's take anesthesia to clinics. Let's take it to smaller institutions instead of just confining it to larger institutions. Nurses have always been an appropriate cadres for task shifting. All we just need is to find a way of working with them. Let's incorporate anesthesia program in already existing programs which have funding. If we start just thinking of looking for funds only for anesthesia, we may not achieve what we want right now. And let's start doing research on the post-TB lung disease. It's something which is growing and which is becoming more and more complex. Yeah. So I want to show you what's here, please. If you have equipment which you have used for 10 years, it has come to the end of its lifespan. The solution is not to send it to Africa. This is what you create. You've seen graveyards. Why? I'll give you this example. In the USA, your electricity frequency is 60 Hz. Mostly in Africa, it's 50 Hz. So this equipment is actually meant to, their mother bodies and whatever electrical components of this are meant to work in a whole different electrical systems. When you take them to Africa, they'll blow up because they're not meant for there. That's one. Secondly is there is no technical support when these things break down. It is more costly for that hospital which doesn't have any money to be able to send back here to the US to be able to repair this monitor. Why? Okay. So the other ones that I would like to show you is that there are case studies which are actually working, and I think people can just be able to look into them. Lifebox is one of them. It's making things which are actually very compatible with low resource settings. They're able to train the people in the low resource settings. They've got long battery life. They are quite, they are good for the environment. And they're able to last longer. It's not only Lifebox, there's also Gradient Health System. This ventilator is able to work off electricity. There are a lot of places with erratic electricity supply, it's able to work. This is Gradient. And then also, Diamedic has made the Gloucester vent also. It's very portable. So even when you're going to do outreaches, you're able to do that. So if you have that care station, that complex anesthesia machine here, if you send it to Africa sometimes, it may be a ghost machine or it may have limited use. Okay. The other ones that you can look at is Smart Train. I love Smart Train concept in the sense that I think they are one of the few who have understood to say is that if you have to sort out a surgical problem, you have to train both the anesthetist and the surgeon and the co-workers around it. That's the concept they're doing, and I think it's working very well. The other one is Partners in Health. Partners in Health have decided to build a university in Rwanda, which is called the University of Global Health Equity. So initially they thought of bringing students from Africa, taking them to Harvard for training. And then I think Paul Farmer and the colleagues really thought around it and said, it's better we actually train them from there. There will be better retention as well. And then just making them going to Harvard to just have a small experience, but their core training being based down there. Yeah. So these are more questions. I won't ask them that much, but the things we need to ask ourselves is, are we heading in the right direction? Why are funds for medical solutions, very difficult to find, but funds for wars are easy to find. Why are anesthetists not interested in the disease of the poor? And then the last one is, should anesthetists rely on goodwill to be able to serve the poor? I have no answers to those questions yet. Yeah. So in conclusion, stakeholders, we need to start collaborating and talking to each other. Let's stop working in silos. Thank you so much. Any questions, comments, or contributions?
Thank you so much. That's an excellent talk. And I think it's a great reminder because it was less than 10 years ago that surgery and anesthesia actually made it to the list of global priorities in the United Nations and World Health Organization. So I think it's a really great reminder to kind of tie back surgery and anesthesia as an integral part of healthcare in general. So thank you very much for this excellent reminder. Any questions from audience members here in person?
Thank you so much for your talk. You mentioned political will and that as the most important pillar to affect all the others. Can you name some examples of some good of political will that was successful in changing healthcare priorities in any countries you've worked in or studied?
Okay. So the one political will that I'll actually mention to you, you know how the USA funds countries for aid? They use that organization. It's not, is it an arm or an organization? USAID, okay? Yes, but the way USAID works is that it's got to approve a lot of programs in USAID requires the Senate to approve funding for that, okay? So in somewhere around 2000, you know, the population of actually the sub-Saharan Africa almost halved, like they were dying from HIV. The treatment for HIV was there, had been discovered, and it was being used globally, but it was not accessible in Africa, okay? So when George W. Bush saw that he could not go around the nitty-gritty details of USAID, what he did is he created PEPFAR. And from PEPFAR, he was able to actually fund the HIV programs. And he saved people in the sub-Saharan Africa, even up to date. Even me, I can tell you is, if there are some of the people that I've got great respect for, is George W. Bush for what he did. That was a bold decision he made to actually fund HIV. And up to now, a lot of people have actually benefited to that. That's political will.
Thank you, great talk. I may not need, but I wonder, just recently in our own ICUs, we've had some notable cases of TB, which have, they're rare, but they still come up, and they always push us to think about the diagnostic uncertainty, the diagnostic challenge, the social factors around TB. Just reflecting on some of those things here, I wonder if you can speak a little bit about the interplay between immigration and TB. I've noticed that perhaps there's an unwillingness for immigrants to make contact with healthcare systems because they might feel that either they get found out or the risk for prosecution, but that also makes it very challenging to monitor or to detect TB and often present late. And I wonder, first of all, is that a problem in the countries that you've worked? And if so, how have your healthcare systems managed to mitigate that tension between immigration and communicable diseases like TB?
Okay, no, thank you for that question. That's a very, very important question. So as I had said earlier on a certain slide, which slide was, yeah, here. So the thing is that countries have already made certain rules which are actually a bit discriminatory against having TB. So even an immigrant, when they go there, they don't want to find themselves in that conundrum, to say. So I think, as I was saying, political will is the most important. If we can decriminalize, if we can even say that even if you're an illegal immigrant or you whatever, please, if you've got signs of TB and whatever, let's have a safe corner where you can actually go and get tested. That's the only way people will actually be free to, because they don't want that's why they're illegal. They don't want to be sent home. Because if they have to go there now, they have to present, their ID, their papers and whatever. They would rather actually stick at the background and continue propagating the disease. So I think that problem is actually falls under governance systems. If we can put up safe corners for this, the same way we are trying to, like I'll give an example in our countries where like the LGBT is something new to us. So to allow people, for example, in the LGBT community to access services, they've made what they are calling safe corners for them, where there is no judgment, there is no whatever, where you can go freely and get access to that. I think those are some of the things we can put there. And we make TB treatment and services free.
I
Thank
think
you.
even with legal immigrants, I think the economics of seeking healthcare is also a huge deterrent, which we all are very familiar.
Yes.
Other questions?
Yeah. So like to just show you like this, look at it. Even if you are poor and 567,000, where are you going to get this amount of money for you to get treatment? It's prohibitive already.
Can you mention the role of vaccinations in TB programs? Is that something that is supported or maybe specificity or severity of diseases?
Yeah, there is still, BCG is still given and it reduces the severity of the disease, but it does not prevent the transmission. The biggest issue we are having right now is transmission. If we are unable to, if we cut off the transmission from person to person, we can actually fight it. Unfortunately, BCG reduces the severity of you when you have the disease, but it does not prevent you from actually getting the TB infection and being able to pass it on to another person. That's where the challenge is. So even the research in TB itself is very limited, and the disease itself, it's quite complex to actually, if you think about it. It's one of the few diseases which actually get resistant very well. It's a smart bacteria. It gets resistant very easily. And if it's for drug resistant TB, BCG won't even work at all.
How many anesthesiologists are there in Lesotho?
So in Lesotho, I'm the only anesthesiologist at the moment. That's against the population of 2.3 million. And my focus is on TB. So I don't know what other factors or the other diseases, how they are actually getting to have that access. So the issue that I've seen is that in Lesotho, because there's no medical school, so they are also unable to train or develop up programs to be able to capacitate the country as well. So it's a country that I think needs support in that area.
That's actually a great segue into one of the questions we got from the Zoom audience. Is there an organization which enables practitioners in the United States to mentor students in foreign countries using technologies like Zoom, Skype, over the internet?
So in Lesotho, they are using ECHO. There's an ECHO, there's a program which is for actually under the Ministry of Health. It was actually initially for COVID, but I think it's something that—
So it's called Project Echo, isn't
yes,
it? Yeah.
Project ECHO. So I think it's still ongoing, and I think it's something that you can still ride on. But unfortunately, as I always say, You can't teach someone how to intubate on a screen. At some point, you still need to show them how to do it.
Project Echo is still running, and they're out of actually the University of New Mexico, and they have basically Echo hubs all over the world. Stanford, our department, we worked with them during the pandemic quite a bit on oxygen trainings. But yeah.
Great talk. Thank you. And, could you speak? So you're the only anesthesiologist in Lesotho.
Yeah.
Right now, there is none then, if you're not there. And in sub-Saharan Africa, the number of countries that have one of the highest rates of children in the world, as well as the lowest rates of anesthesiologists. Could you speak of, I'm a pediatric anesthesiologist, the needs for the care of the children? You spoke of a bronchoscopy for a child, which you can't do awake, unlike an adult. How is that managed in sub-Saharan Africa or in other places?
No, thank you so much for that question. It really breaks my heart to say, but unfortunately, there are no people to manage children. And I can tell you is that the highest mortality of TB is actually among children, because one, we're unable to even get a bronchoscopy or bronchial washings to be able to actually diagnose them. So we are unable to make a diagnosis why we don't have pediatric anesthetists to be able to diagnose them. We don't have pediatricians to also be able to do bronchoscopies and all that. So it is what you have said, it is actually a reflection of actually what's even on the ground. That's why there's a high morbidity and mortality in actually children in comparison to adults. I'll just share with you, like 4 months ago, we had a child who were suspecting the parents have drug-resistant TB, both parents. And the child started losing weight, was coughing, but we could not get a sample from the child. Why? There is no equipment that we can even use for first to anesthetize that child. So all we just tried to do is we made a brave decision to say that let's just treat this patient. We'll do a risk benefit and be able to do, and we're lucky it's because we are specialists, they are able to do that. But that's just in one center. So in all these other centers where they don't have, the children just end up dying. So as I was saying is, we need to collaborate. Health workforce, we should not just be saying we need an infectious disease. We need a pediatric anesthetist. We need the obstetric anesthetist. I showed you just that example of that woman who had those fibroids but had TB as well. So we all need all those services just for this one disease, which is TB.
I think some of you probably know, but the World Federation of Societies of Anesthesiologists just updated their anesthesia workforce map. So the data before was from like 2016, 2017, and it looked at the number of anesthesia providers, physician and non-physician across the globe, and it puts it into this really nice visual map. And it did demonstrate that the numbers are going up, but still grossly inadequate in many, many places. But I think, as you know, Dr. Fair, the WFSA also has a lot of pediatric fellowship spots that they've created. So people are going into more pediatrics. And then through our division, the work in Rwanda, we're also working toward developing a pediatric fellowship now. And some of your faculty are actually intimately involved in that process too. So there's definitely people out there working and trying to make things better.
Yeah. And then the other thing I wanted to say is that, remember what I was trying to say is that we're making training even more complex, and we're also not trying to do task shifting in it. For you to become a pediatric anesthetist, first you have to become an anesthetist, okay? Which is a very good thing, and that's the direction we should be going. And that should be the long-term goal. But whilst we're heading in that direction, why can't we face the general anesthetists we're training? Why can't we increase, for example, a bit more training for them in pediatric anesthesia so that they're quite competent as well, so that even those who don't go on to become pediatric anesthetists, they've at least got a good touch and background to be able to manage children well. Whilst as a short-term goal, whilst we are training more pediatric anesthetists in the long-term goal. But from what I'm seeing is that we keep on reducing more and more of the curricula at general anesthesia so that we can push it more towards the fellowship side, which is denying other trainees that opportunity to be able to work.
Any other questions? Okay, great. Thank you again, Dr. Sheyo, for this wonderful talk. Thank you.
Thank you so much.